I don't know how that ever got to be a prevalent practice, but it's very disturbing, right? So in
Mm.
my medical record, if I needed to do something and I knew this carrier was one that had a policy on bundling, in order for me to get paid for my comprehensive eye exam and my fundus photo, I have to show that I examined the fundus physically first, saw something that was photo worthy and required documentation from a medical necessity standpoint, and then did the test.
Hello and welcome to Compliance Corner with Dr. John Rumpakis and Dr. Chris Wolfe. I'm Dr. Chris Wolfe, and with me today, obviously, Dr. John Rumpakis. John, say
Rumpakis. Hey.
So John, thanks again for doing this. We're going to get our stride as we do more of these. You know, in today's episode for this month, what I wanted to focus on, what we've seen, you and I have been talking about on the side, is the 25 modifier and the 59 modifier. And I would say that probably historically, I would say that the 59 modifier is probably the most utilized modifier in optometry and probably the most misused modifier in optometry. But now we're seeing like the 25 modifier get some more scrutiny. So I want to talk about that today. First of all, John, tell us what the problem is when you're seeing this from kind of CMS alerts, working with practices where they're getting themselves into trouble. What's the problem?
Well, Chris, I mean, this has become a really big issue in the last, I'm going to say, since middle of 2025. So modifier 59, modifier 25 are the top two modifiers that are used to break the CCI edit rules that exist. And the CCI edit rules, just for everybody's edification, are the federal set of rules that are updated on a quarterly basis at the very minimum that dictate what tests or procedures can be performed on the same date of service to a individual patient. There's, a little over 1 million different code combinations that are out there. And whether or not you agree with the rule or you don't agree with the rule on what you can and cannot do, you're obliged to follow the rule that is out there. Modifiers 25 and 59 are the two most common modifiers that allow you to break that rule. However, they both have significant downside if used inappropriately. So much to the fact that the OIG has recently announced an entire project that was running through 2025 all the way through 2028 that is focusing specifically on the misuse of modifier 25 since it's being misused so much. Much of this started with retinal specialists doing injections, as the rule used to exist is that you could bill for an office visit on the same day as a retinal injection. CMS and the OIG made a determination that that is no longer the case. And so what people were doing is using modifier 25 to override that code combination. Obviously, we know the prevalence of retinal injections is very high. It's a high dollar amount to Medicare as well. And so now they've, issued new guidance as of the fall of 2025 that said, hey, no more of this, right? You can't do it. Everything's bundled together on the same day. We also saw this happen on October 1st, 2025 with OCTA and any 92,000 level service. And for those of you who are PPP members, you know that we wrote a brief on that, had that out about 3 weeks before that rule actually went into place. So you were well advised of this. In order to use those modifiers correctly, the medical record definitely has to contain certain elements that allow you to justify the use of those codes. And, you and I can take those one by one if that's what you'd, prefer
Well, yeah,
to do.
I think you set it up really well. And I would say, let's start with 25 modifier. What would the chart generally have to say to support a 25 modifier in? So, okay, I want to back up because you talked about retinal surgeons. Most of our listeners are not retinal surgeons, but like, if I needed to perform a procedure, let's say lacrimal dilation and irrigation
Mhm.
on the same day as another service, forget about
Mhm.
what the other service is. Doesn't matter. What do I need to establish in my record in order to support both of those if I were going to unbundle them, essentially?
So let's say, for example, a patient came in, let's say you were going to see them for a glaucoma follow-up. They were
Yeah.
just coming in and they were there Their intent, the purpose of that visit was to do a follow-up to evaluate their IOP, their visual acuity, and you were going to take a look at the retina, observe the optic nerve. During the course of that, you said, hey, you've got a plugged, orifice. We need to go ahead and dilate and irrigate that because it's not functioning properly. So what can I bill? Because my office visit that I'm performing still represented acuities, IOP, evaluation of the retina, right? I still can get paid for that, right? That's a distinct and separate evaluation and management activity. And that's exactly what the definition of modifier 25 is. It says, I need to state that the medical record shows that something that I'm doing is distinct and separate from this surgical procedure. Because as we know, minor surgical procedures, including retinal injections, those have an office visit automatically built into the reimbursement already. So if I was just to bill a 99213 and I'm trying to think 68440, I think is
something
dilation,
like that. Yeah, I can't.
Something like that.
I did it yesterday, but I can't remember.
If I was just to do those two things, the office visit would get rejected. So the work that I did to evaluate and follow up that patient's glaucoma situation, I'm not getting compensated for, but I should have. So an appropriate use of modifier 25 on the office visit would allow me to get paid for the amount of the office visit work that was unrelated to the dilation and irrigation of the puncta in that setup. Same thing with when we visit OCT in the rule, right? Because they bundled those together because so many people were doing those together on the same date of service. Now, if I want to get paid for an OCTA and a comprehensive eye exam, I have to clearly demonstrate in the medical record that procedure, that special ophthalmic test that I'm doing, was because of a finding that I found during the course of the examination, and I had to make sure that I needed to let the record know that this test was medically necessary to do. And I would put a modifier 25 on the office visit itself. We're seeing this happen, incidentally, just to kind of keep all the viewers aware across the board. Carriers have interpreted this as a free-for-all. I got a call yesterday from one of our members who said, I did a visual field and fundus photos on the same day with a patient who had macular degeneration, and both of those tests got denied because they were done on the same day as a comprehensive eye exam. So the carriers aren't following the rules, and that's why it's very important that we make sure that we're submitting our claims properly and we know what the rules are so we can fight those things effectively.
Stop feeling overwhelmed and start running a safer, more profitable practice. Here's the next step. First, book a strategy call with us, Practice Performance Partners. We'll uncover the biggest risks and opportunities in your practice. Then, choose the package that fits your goals. From there, we'll get you launched with confidence, with clear systems, with expert support, and with peace of mind, knowing your practice is protected and set up to grow. Don't wait until something goes wrong. Book your strategy call with us, Practice Performance Partners, today. Oh, no, one of the things I was going to say, one of the things that is kind of a bad habit, I don't know where we picked it up, but it's a bad habit I see in charting all the time, where I think it would be very hard to defend on that comprehensive exam if my documentation, because you'll see this a lot, it might say the chief complaint or reason for visit might say patient here for full exam and macular OCT, or patient here for full comprehensive exam, right, and fundus photo, right? And in those cases, it's really difficult to say, well, first, what's a comprehensive exam? There's no medical necessity for that, right? So throw that out. But if it said, let's remove that out and say patient here for macular OCT. And then you have a number of history, like patient feels vision is stable, or vision is wavy, whatever. But now all the reason for visit is macular OCT. It's very hard to say there was a requirement for a separate and distinct service like a comprehensive exam to go along with that macular OCTA, right? However,
I'm sorry.
I was going to say, however, probably a more clear chief complaint reason for visit might be doctor-directed return visit for cataract evaluation and glaucoma evaluation and macular evaluation, or any of those things.
Sure. The
patient
more
reports,
specific
good
that you are,
adherence.
yeah, the more specific you are, the better. What I find happening though quite a bit is, well, let's take retinal imaging, fundus photography. So I have gone into practices where the doctors are not even doing ophthalmoscopy anymore. No
Right.
direct ophthalmoscopy, and they're substituting a fundus image. Okay, ultra wide field, whatever your
Yep.
your preferred instrumentation is. So the way the carriers are looking at that is they say that that is substituting for a required element of a comprehensive eye exam. And so the reason we're not going to pay you for that fundus photograph is that you didn't do the full service in what you're supposed to do. So you're using this, you're not going to get paid twice for a full comprehensive eye exam. You didn't even look at the retina. There's no notes on your direct examination, no notes, anything. There's just a photo and an interpretation of the photo. And so that's why the carriers are saying we're bundling this together in many cases, right? And so I've seen that happen quite a bit, where doctors have just abandoned ophthalmoscopy. I'm not sure where I don't know how that ever got to be a prevalent practice, but it's very disturbing, right? So in
Mhm.
my medical record, if I needed to do something and I knew this carrier was one that had a policy on bundling, in order for me to get paid for my comprehensive eye exam and my fundus photo, I have to show that I examined the fundus physically first, saw something that was photo worthy and required documentation from a medical necessity standpoint, and then did the test. Not a problem. I'll get paid 100%, and I would be happy to defend anybody in that situation in an audit. But when your medical record is substituting things, OCTA was a great example. People just abandoned regular OCT of the retina and they started doing OCTA on everything. One of the
Mhm.
things is that you have to understand is that you have to demonstrate why you needed to add the angiography component on top of the retinal OCT. That's what 92137 is. And if you even look at the definition of the code, it says retinal OCT with angiography. So you have to make sure that you're showing the justification for doing those extra things or having that extra information. I mean, I know it's a nice to have, right? Everybody likes to have the nice to haves, but medical carriers want to have the need to haves, right?
Right.
That's what they base things on.
Right.
And I guess I would say, as a good transition into modifier 59, on that, that's kind of goes into the nice to haves versus the must to haves, because the number one offense of that in eye care, of course, is the use of fundus photography and OCT on the same day of
Yeah,
service.
exactly.
And you and
Yep.
I see that happen
All
daily.
the time.
Yeah. And I can't tell you on whatever other ODs on whatever you're on, my God, the justification that I see for doing that sort of thing that people come up with that have absolutely nothing to do with the actual rule itself blows my mind. I
Yeah.
mean,
Well,
I've
it
seen,
always starts with, do OCT and fundus photography on the same day and get paid, right? Like that's the
right,
headline or that's the tagline. It's just like, just come on, just take care of the patient, do it the right way.
right. I mean, so tell me, I mean, you're from a clinical basis, you're way ahead of me since I'm not in clinical practice. But my God, I mean, tell me the situations from a clinical basis that you would actually say, it is absolutely necessary for me to do both of these on the same day in order for me to manage this patient better, right? I mean, maybe
I can almost never find a situation outside of perceived patient convenience, perceived practice convenience, right? It always
Mhm.
comes down to, well, the patient doesn't want to come back. I don't want to ask the patient to come back, or
Right.
I don't want to have to have the patient clutter up my schedule, right?
Eh,
None of those reasons. I mean, could I find sure, I could find a reason, right? I could.
Right.
But
Maybe
like
a
those are
CRVO, something like
sure.
that you're looking at. I
Yeah.
mean, that you've got to document is you want to know exactly what the status of that patient
You
is,
cannot
both
wait till tomorrow. Yeah.
right. But
Yeah.
otherwise,
Almost
I'm not
never.
sure. I'm not sure why a practitioner can't say, Mrs. Smith, we need to do these 2 tests. Your insurance carrier doesn't allow these both to be done on the same day. So what we're going to do is do this one because I feel it's of the most clinical importance. And then I'll have you come back another day. You don't need to see me. Just come on in. We'll get you scheduled to have the test done. And then I'll call you with the results after we're finished. It's so easy to not violate the rule, but people again get complacent, or they figure out, I mean, I want to go around it, or somebody told me to use modifier 59. And then what that does, of course, is just raise, I mean, that's almost like raising your hand and saying, hey, come look at my records, right?
Yeah.
Because modifier 59, if you actually look at the history of it and the amount of publication that the OIG has on it, and if you're a CodeSafe Plus user, you have all of that built into your knowledge bank anyways in the OIG section. But modifier 25 by design is a modifier of last choice. That means
Modifier
that none
59,
of the other
59. 59?
I'm sorry, what did I say?
You said 25. It's okay. We're talking
I'm
about
sorry,
both of them.
modifier 59.
Modifier 59.
Yeah, absolutely.
Yeah.
Yeah, modifier 59 is a modifier of last choice. So that means I get to go through the other 75 modifiers that are out there. None of them apply to the clinical situation that I'm in. So 59 is the only one that I'm left with to use to describe that clinical situation. I don't think that that stands up very often, not at least in my experience, because the medical records that I see just are nowhere near being able to defend that posture.
This is super helpful, John. I think we've kind of laid it out well. First thing is, obviously, people know what they ought to do when they're considering both the 25 and the 59 modifier. If you're I'll give you a couple different resources. First, if you're a Practice Performance Partner Pro member, you have access to CodeSafe Plus. John Rich discussed that. You also have access to a course called Mastering Modifiers. You also have access to a course that John did that was called Practical Application of 92135 and during a comprehensive exam, and then
92137. 92137.
Yeah, thank you. Yeah, we both 92137, and then you have access to that course. It's all included as a PPP Pro member. If you have any other additional questions, please feel free to reach out to us. John, thanks so much for joining me this month, and I can't wait to do the next one with you.
Very good, Chris. Thank you. Appreciate it.
Appreciate it.